Okay, so we've got a T2 weighted MRI here. Just first glance, what do you think about these liver lesions?
Super bright, and I see some of these in the vertebral bodies as well.
Good pickup. So there's some stuff in the vertebral bodies, but just like if you're looking through the liver, what's your first impression?
Cyst versus hemorrhage.
Yeah, exactly, right? It looks like a lot of cysts.
Well, some
One
of them
thing
don't look, they look complicated. Some of them look complicated.
yeah, and
Hmm.
they kind of have like this dark T2 hypointense rim, right? So like not totally cyst, but you know, more likely cyst than a lot of other things. Okay. Um, Here is the arterial phase. It's a bad, there's a lot of motion, respiratory motion, but like, just as an example, this is what they look like on arterial phase. So that
It
looks
happens on
like,
the venous. Oh,
okay. So yeah, already these look unusual for cysts in that they seem to have rim enhancement, and cysts should just be like black holes, like without rim enhancement. And then this is the delayed phase where you kind of don't see them. So they seem to be filling in.
Meds from mucinous adenocarcinoma.
Great thought. So I didn't tell you the history. There's no way you would have known this, but I'm going to give you some more history. So the patient has HIV, and there's also these bone lesions.
Kaposi.
Yeah. So this is biopsy proven Kaposi sarcoma in the liver. Um, so just wanted to talk a little bit about Kaposi's. I found a paper from Abdominal Imaging from 2021. I don't know. Should I bring it over? Okay, let me bring it over. Okay, here. Imaging of Kaposi sarcoma, 2021. Yeah. And I just wanted to talk about the liver, but Kaposi's can be endemic. It can be in the setting of HIV. And then in the liver, the most common manifestations are hepatomegaly. And then also I've seen like periportal soft tissue, the same way that there's like perivascular soft tissue that you see in the lungs, like the flame-shaped thing. And then the other thing is they can be like multifocal lesions that mimic hemangiomas. And I think this case is like kind of similar to hemangiomas. They're T2 bright, they have delayed enhancement. They don't have the peripheral nodular, they had more like rim enhancement. And then the key is like the history. But anyway, so this patient, like, was not known to have Kaposi's in their liver. They did this MRI. We brought it up. We said these are unusual, but given disseminated Kaposi's in this patient, also probably in the bones, they biopsied it, and this was Kaposi's.
did it restrict?
Oh, let me show you.
So I guess it's really bright because it's a vascular neoplasm.
So the TWI is not great, but anyway, yeah, it seems like, so this is the high B value, and they're definitely
Yeah.
bright. And then I'll show you the ADC. So they're shining through.
Yeah, because yeah.
So, I mean, if this patient didn't have Kaposi's and I saw all these T2 bright things with like rim enhancement, but then delayed enhancement, I guess the two things I would think about is what you said, mucinous mets or abscesses. And like obviously patient HIV can have abscesses and infection, but this turned out to be Kaposi's. Yeah, it's a case.
I have a companion case of Kaposi, but still not companion. Should I show that?
Yeah, sure. Yeah.
So this was a 45-year-old man with HIV, and the patient has soft tissue around the duodenum and along the mesenteric vessels. Patient also had these violaceous lesions on skin, which is classic for Kaposi, and it was biopsied and it turned out to be Kaposi sarcoma.
This
So
is
all
the
of that
beautiful.
mesenteric infiltration is Kaposi?
Yes.
Yes, and
Wow.
this is a teaching point I really want to drill home, is like that perivascular soft tissue is really classic. So it can be along the mesenteric vessels, it can be along the iliac vessels, the portal veins, and then that same kind of perivascular stuff is what's happening in the lungs that gives it the like flame-shaped thing. So whenever I see like the history of HIV and then any perivascular soft tissue, I'm very suspicious for Kaposi. And also Kaposi's can hit the GI tract, and we often just don't see it on imaging, but they see it on endoscopy. So if they don't have like the classic skin lesions, I think one of the most popular areas is like they'll see it on endoscopy in the GI tract.
In fact, a couple of months back, I can't find it on my X. Dr. Itani from Malincrot, she had posted a case in which there was so much soft tissue around, like so much soft tissue thickening of the anal canal and rectum, and there was lymphadenopathy in the retrocrural area. And she just posted it as an unknown case, and it was a male, again, 30s, HIV positive. So that was Kaposi. We were thinking in terms of lymphoma versus, because it was soft tissue and there was not much stranding.
Actually, if you have proctitis, you can also think of mpox now.
Yes.
But one thing, now that I'm reading your little summary here, it's this is exactly what I was saying. Like the most common visceral manifestation is the GI tract and the duodenum. So that's what we saw in our patients. Like a lot of times the actual diagnosis came from their endoscopy, but then, you know, we would see non-specific other things like liver lesions or hepatomegaly and but yeah, the GI tract I think is kind of an underdiagnosed area for us.
So this is slightly elderly female, and she comes with urinary symptoms.
It's like the female prostate sign. What is?
Yes, I was about to say.
Can
You
you show
show
the
my,
sag? Like,
yes.
is it connected to the urethra? What is it connected to? Or is it just in?
But the case that you had shown was outside urinary bladder. This is inside the urinary bladder.
And it's not really arising from the urethra. It seems to be arising from the bladder.
Mm-hmm.
Okay, need some more images. It doesn't look like a urothelial cancer because it's so smooth.
Mm-hmm.
One option is a leiomyoma. Does it have like homogeneous enhancement?
I mean, I do not have post-contrast images, sorry, but yeah,
What?
I mean,
What are you guys doing in Iowa? What do you
no,
mean?
this is an old scan, like
Oh.
really, really old and from outside. So yeah, I mean, the basic teaching point here was this T2 signal intensity, and it was indeed a leiomyoma. And when they did cystoscopy, so they found a stalk which was coming off of the urethra, mid urethra, and then this mass was going superiorly into the bladder. It was acting like a ball valve mechanism, and that's where the patient had the urinary symptoms.
Cool. That makes sense. You can get leiomyomas of the bladder wall, but they're more kind of like the smooth, like pebble under the carpet kind of appearance. And then you can also get them of the urethra. I guess anywhere you have a smooth muscle.
Mm-hmm.
Nice.
So this was the paper that got the best GU award paper from SAR. Quinn Baker is one of our abdominal radiology fellows. And the question is, is DCE helpful in risk stratifying patients? So it's a classifier. It's kind of like an ancillary feature for PIRADS, right? Just like LIRAD's ancillary features. So its role is only within PIRADS peripheral zone DWI3. That's it. That's the only place where it has any meaningful impact. So if you have a peripheral zone lesion that's DWI3, if it has enhancement, then it gets upgraded into a 4. And if it doesn't, then it stays 3 overall category.
And the
Within
difference there between 3 and 4 is like often they'll biopsy the 4, but maybe they will watch through the 3 because it won't be as clinically significant.
Correct. Yeah. So some places stop now biopsying 3 because the yield for 3 is about 20% for clinically significant prostate cancer. And it's about 45% for PIRADS 4. So it's double, more than double. Okay. So the question is this PIRADS pathway useful? Like does it have any impact? Like, and then when we look even within PIRADS 4, this is only peripheral zone lesions. Within PIRADS 4, there's actually 3 separate groups. The ones that get upgraded, and then within DWI4, you have the positive and negative DCE, but the positive negative here plays no role in the actual outcome of the PIRADS category. So our question was, what is the difference in rates of clinically significant prostate cancer among these three tiers? You know, PIRADS has 4A, 4B, 4C, right? It's risk stratified within PIRADS 4 category, but we don't do that in PIRADS. And this is in the background of the PRIME trial. So the PRIME trial is a huge RCT looking at biparametric compared to multiparametric. And it's expected to show that biparametric is non-inferior to detecting clinically significant prostate cancer compared to TRIBE, right? So this is saying, look, we're not going to need DCE. That's what this trial is going to be showing. So that was our question. So
just
what
for
we found,
the more novices of the group, so biparametric prostate MRI is with T2 and DWI, and then what's the other one called? Triparametric?
multiparametric.
Okay, multiparametric then includes contrast and dynamic contrast enhancement, DCE, which you're trying to say like, oh, is biparametric okay, or does DCE add anything?
Yes, workflow wise, biparametric is only 10 minutes.
Yeah.
Right. You don't need an IV. You don't have to worry about gadolinium. You don't, multiparametric is 30 minutes or more. And there's this whole IV stuff that you have to deal with. Operationally, biparametric is like amazing and it's fast. So there's a cost component implications for biparametric.
Okay, so now convince us that we need the DCE.
In some, it's not for everything, but for some things. So we had 45,000 MR exams, and we excluded all patients with prior cancer history. So, and then in patients without known cancer history, we broke it down into the 4 groups, right? The 3 subgroups within PIRADS 4, and then the PIRADS 3. And then this is what we found. This is clinically significant. So the color coding. So this is negative. The blue is grade group 1. And then as the kind of colors increase, the grade group increases. So the red is grade group 5. So clinically significant is anything that's 2, 3, or 4, 5, right? So if you look at the 3 subcategories of PIRADS 4, the yield for clinically significant prostate cancers increases by like almost 50% with DWI 4 with positive DCE compared to the other 2 subgroups. And then if you look at just the high risk, so there's some people will survey grade group 2, Gleason 3+4. That's considered low intermediate risk. But 3, 4, and 5, grade group 3, 4, and 5, nobody would argue that this needs like treatment, active treatment. And if you look at that, the yield is again almost over 50% compared to the other subtypes, the other 2 subcategory.
And for like the PIRADS 3 that goes to 3+, I mean, it's more than 50%. It's like tripling.
I'm sorry?
It went from 7 to 22. So like for the
yes,
yes,
that's exactly right. The DCE triples the risk of that's exactly right. But and if you look at this, a PIRADS like a DWI 4 that doesn't have DCE, it has the same performance as a 3+, right? So DCE is really important. So the minute it has a DWI that's restricting, like high, high and like bright on high B value and dark on ADC, and it has positive DCE, it's like legitimately high risk compared to the other group.
Okay, so how do you explain the PRIME trial potential results that the enhancement doesn't matter?
That's for detecting. This is risk stratification, right? So
they're not looking for like clinically significant. They're not trying to say clinically significant or not. They're just saying detection of any prostate cancer.
Well, they're clinically significant in 3, 4s, and 5s, right? So they lump up the whole group.
Got it. Yeah,
them
this
all
is
together.
more nuanced. Yeah.
And this is more nuanced, exactly, right? Like PIRADS 4, they're not all the same, right? So if you're going to have a PIRADS 4C, that you're going to treat that more aggressively than a PIRADS 4A, because we know the yield is much lower for a 4A. And that's what we're arguing is in the same way, like DCE effectively risk stratify grade group. And patients with positive DCE has a much higher risk for harboring aggressive, high-risk prostate cancer than those without DCE positive. And they're different risk groups, basically. And that the next iteration of PIRADS should really be taking that into account, that all PIRADS 4 are not the same.
Cool. So you kind of are suggesting that they should do like a PIRADS ABC or something.
Something like that, yeah. There's different risk. And that DCE does help, and that binary classification, that it should probably also exist for DWI4, not just for upgrading a DWI3 to a PIRADS 4.
Yeah, to be honest, like as a reader, I didn't pay as much attention to the DCE because I'm like, it really doesn't make that much of a difference, except in that one tiny category, you know. But yeah, you've convinced me. Cool, thank you.
We've
And
achieved
congrats.
Oh, thanks.
No.
So the interesting thing is when we actually included and excluded patients, we found out that there was like a tremendous amount of variability in how radiologists reported, and that we didn't consistently follow PIRADS workflow. So PIRADS says if it's a DWI3. So a definition for DWI3 is it's not marked, but it's bright on high B value DWI and dark on ADC, but it's not markedly like bright and dark, right? So if it's markedly bright and dark, then it becomes a DWI4. But if it is bright and dark against the background, then it's a 3. And ADC is not included in the PIRADS. And what we found, because Quinn was looking for cases to present, was that people weren't following PIRADS. Like, we would only call it bright and dark if the ADC was like lower, at the range that we wanted it. So even though qualitatively it was bright and dark, we wouldn't call it. So he actually had to go through like 30 cases to get a couple of cases that fit the actual PIRADS workflow, right? So here is a DWI3. So it's bright on high B value and dark, but it's not marked, right? But it's bright and dark compared to the background. And so that would be a 3. So in practice, we wouldn't call this a 3 because it wasn't the ADC. If it was measuring 1,000 or 1,100, like we just wouldn't call it. And then in this case,
We're
enhancement.
under calling the PIRADS 3s because we were looking for like the marked.
Yes.
Yeah, I mean, I wouldn't call that. That's like a tiny, it's so weak.
But this is what PIRADS 3, DWI3 is in peripheral zone, is against background. It's qualitative. This is a 3. And then it gets upgraded into a 4 because it has enhancement.
It's also like wedge shaped. What did this turn out to be? Oh, I see.
It was a grade group 2.
Got it.
Yeah.
Cool.
And then this other case, this is marked, right? And everyone would agree is like super bright and then dark on ADC, and then it had enhancement. So this came back to be high risk. So grade group 3.
Okay. Thank you for the research update. And that was awesome. And we'd love for you to bring more prostate cases, maybe even give a whole lecture.
Mhm.
Okay, who's next?
Nice.
Oh,
Was
This
this
is
already shown? Ovarian torsion?
Oh,
wait.
did I already show this?
Did you show this already? But yeah, it looks like ovarian torsion.
Sekhar showed this perifollicular sign. Oh, yeah.
Yes, it looks very similar to the one I showed like last 1 or 2 weeks ago.
Oh, you showed it. I didn't. Did I show this? I don't remember showing this.
No, but what we're seeing is massive ovarian edema, peripheralized follicles, maybe even, perifollicular hemorrhage.
Yes. Here, let me show you the T1.
Oh, that's impressive.
So let me give you a little bit more history. So the patient had endometriosis, had an endometriosis surgery a couple years ago, then had pelvic pain, got an ultrasound where she was, and then they called it a pelvic mass. So then she came to us, and then we got an MR, and then this is what we saw in MR. We don't have the ultrasound images, but we have the MR. So exactly what you're seeing, right? So the pedicle is here. You have a massively enlarged ovary. There's hemorrhagic, like hemorrhage within the follicles. And then you can almost see that swirl sign, like an MR equivalent of the swirl sign that we would, that we see on typically ultrasound. But here it is. Here's the pedicle, and you can almost like see it twisting.
And then the perifollicular hemorrhage is supposed to be a sign that like this is necrotic. So post contrast was this ovary like
Here's a post-cons, and there is hypoenhancement.
yeah.
Right there.
Mhm.
And I want to show you.
But it's
the,
not
like,
non-enhancement. It's just hypoenhancement.
Because the ovary per se is not dark. Like the case that you showed, the ovary, the parenchyma
like
also
black.
become dark. Yeah.
Yeah.
I mean, it's not enhancing very much. Yeah.
Mine was like completely black. But anyway, yeah.
Oh, I see. Okay.
Yeah.
And then this is what the laparoscopic the surgery showed. It was twisted around the round ligament, and our gynecologist said that it looked dead, so it was resected. Completely resected.
That's a beautiful intra-op correlation.
Isn't it?
Yeah.
Yes.
And it does look like it's hemorrhagic. Like you could see that ovary was like edematous and hemorrhagic. Thank you. Yashant, do you have a case?
Yes. So we have this MR and we have this T2 sequence. And we're focusing around the right kidney, hilum.
Yeah, there's
So what
something
do
in the
we see?
hilum. You have
I feel like
contrast.
a lot of
both
flow
on?
voids.
And there's is there hydro, a little bit of mass effect causing a little bit of caliectasis?
A little bit of it, yes. And
I want to know, is that a stone or are those flow voids? Like, is that a vascular thing?
Doesn't
or
look like a
stone?
stone. Do you have the postcon? It doesn't look like it's intrarenal. It looks like it's extrarenal.
let me show you motion insensitive sequence.
Oh yeah, look at that. Aarti, there's your.
Yeah, aneurysm.
And I think I have ultrasound also for the same patient. That's the end. So it was aneurysm, and yeah, it was a flow void.
Wait, hold on. On ultrasound, I would that I feel like that would be very easy to miss. Like I would have just
That one
assumed.
was done secondarily. It was seen on MR, and then a possibility was raised. Yeah, ultrasound is harder this time than MR.
Yeah, the flow voids are really helpful.
This is a patient with renal stone seen on ultrasound, and they got a CT, and the focus is not so much on the stone, but on the renal lesion. So there's this hyperdense, and this is a presumptive diagnosis, so feel free to chime in if you disagree. So there's this hyperdense lesion here, and it measured 68 Hounsfield unit.
I was going to say, if it's homogeneous and greater than 70, then we feel like it could be a hemorrhagic cyst. I still think that this is most likely a hemorrhagic cyst.
So what caught my eye was the angular margin. So it has a very wedgy look to it, kind of that ice cream cone sign. So then which makes me think about lipid pori mal. And lipid pori mal are dense. They're very dense. And they're probably
Wait, are they this dense?
They get to be pretty dense. And on ultrasound, this is what it looked like. It's echogenic. So would you support a diagnosis of lipid pori mal based on CT and ultrasound findings? Like I said, it's a presumptive diagnosis.
Why it is hyper on ultrasound?
Is it the...
Yeah, because AMLs are hyper on ultrasound when they're fatty.
Are they also echogenic if it's not fatty? Lipid poor?
I don't think so.
I don't know.
If they're lipid poor, it will be more of angio or myo component, and muscle will be hypo.
And also, Nelly, I do think I agree with
Angio,
what you're
like
saying, that they're,
yeah, like vascular lesions are echogenic, like hemangias are echogenic in the liver.
but this one wasn't really, well, anyway, my thinking is the hyperdensity that you had on CT to me is too dense even for a lipid poor AML, and is much more consistent with a hemorrhagic cyst, which I do think can be echogenic on ultrasound. So I'm still going for hemorrhagic cyst.
Okay, I don't have MR, so I I can't prove you right or wrong.
Mm. But I like, yeah, it's a little confusing, but I do think they're generally hyperdense, but not as hyperdense as a hemorrhagic cyst. The reason they're hyperdense is they're more muscle. And so then, like on ultrasound, I think it should not be echogenic. But
That's fair.
yeah. Okay, this is a patient with lupus who comes in with abdominal pain.
Diffuse thickening of the colon and small bowel loops.
Yes, excellent. So small bowel is kind of thick right here, and then colon is very thick here. Do you see anything else? You'd probably see it if you were doing your whole.
Is there like hydronephrosis?
Yes, there's a little hydro. You can ignore that. This was a great call by my colleague. Basically, she said, the IVC looks weird.
Is it thrombosed? Because lupus can give rise to hypercoagulability.
Exactly, yeah. So it's here.
That's an amazing call.
Yeah.
Oh, right
So,
there is more convincing. Yeah.
exactly. So here's a little hypodense, and then
Yeah.
here, look at this. It becomes echogen or hyperdense. And then expanded, going down into the commons, going down into the externals. But I still think it's a great call, right? Because you could just easily go by this. But anyway, okay. So that was the non-con CT. And then I'm going to pull up the follow-up. Here it is, post-con. We've got our big, oops, wait. Yeah, here's our big thrombus in the IVC, and then it's like hemorrhagic thrombus down here, so it's a little bit more hyperdense, which is why we saw that on the non-con, going into one of the common femorals, but not into the other one. So yeah, it was a really good call. And then IR came along and did a thrombectomy, and this was the follow-up exam. And now we can see that IVC looks great. There's a little bit of residual eccentric thrombus, but most of it is gone. And then as far as the colon, we did look up because just to go back, this, we had all of this like severe edema here. So we were like, is this related to lupus colitis, lupus enteritis? So I looked that up. There is a thing called lupus enteritis and lupus colitis. It's a rare manifestation in lupus, and it's an autoimmune attack on the wall. But in this particular patient, this actually turned out to be norovirus. So they just had a completely separate infectious colitis that was pretty severe. And then because of their hypercoagulable state, they had a IVC thrombus that was able to be removed from IR.
I mean, was there also kind of like a venous ischemic component just because of the pretty extensive venous burden, like thrombus burden?
Maybe, but like all the bowel is draining into the SMV and IMV, right? It's not draining into the IVC, which is the systemic circulation. So we did think about that. Like, is this ischemic? Is it edematous because of that? But the SMV and everything looked fine. Does that make sense?
Yeah.
Like the IVC would make like more like lower extremity edema rather than like actual colonic issues.
Yeah.
Yeah.
This is a CT abdomen pelvis, and there's a left kind of a cystic lesion in the left kidney. What would you call this, or what would you say in your report? And what recommendations would you make?
Depending on HU.
Yeah, and can you scroll up and down? I just want to make sure
Oh,
it's
sure.
well
Yeah.
circumscribed or
Depending on what, Yashant?
HU. So what is the HU?
H?
Hounsfield
HU,
unit.
Hounsfield units.
Oh, Hounsfield. It's, I think 6 or 7.
Then it is a cyst.
Yeah, and actually Corwin's paper says like on portal venous phase, you can go up to 40 if it's homogeneous. The only thing I don't like is the medial edge, and then like why, like when you scroll down, it almost looks, can you show the coronal?
Yes.
Like, does it communicate with something?
Do you go until 40, or like, I slightly trade that off and go until 30? And they also say it is until 4 centimeter, 40 and 4 centimeter. Is that what you strictly followed at your
No,
institute?
there's no way this measures 7 Hounsfield units.
Okay, let me measure for you. Here, I'm going to pause share for a second so that I'm not showing. Okay, I'm going to resume share. Okay, can you see my screen?
Yes.
Do you believe me now? 9.5.
Wow.
Here, let me give you the axial. Oh, that's not axial, excuse me, this one. Let me pause share really quick, make sure I don't have any.
Can you move that little Hounsfield unit around?
Sure. Here, can you see my screen?
Mm-hmm.
Oh, actually here. So
So
I don't,
13.
this one is, I don't know, there's not a diameter requirement, right? For the,
I don't think so, but I do like to move it around to make sure like there's
okay, this
nothing
is
solid or
15,
like, yeah.
10,
Yeah. Wow.
12. How about here? 11.
Okay. Zoom back out. It just looks so solid. It's so weird. Doesn't look like a real cyst. Oh, wait.
I think those rules only work if it's homogeneous. And that's the point I want to make here is this doesn't look homogeneous to me. There's complexity in it. Like here.
Yeah, yeah.
Like it's not a homogeneous renal cystic lesion.
Now I'm wondering if
So
it has fat in it.
this is what
Oh my God. What?
yeah. So and now look at this. There's all of this stuff. Here, let me give you the venous where it shows it a little bit better. Look at this.
So it's a clear cell RCC.
Yeah, it was. Well, this was 10 years later. The patient that one's an old study. We got the records from the old study. But it's easy for us to say, oh, cystic lesion and not mention. But I think if there's a component of complexity to it, it doesn't matter what the Hounsfield unit is. I think they still need to get MR or follow up.
Yeah, this, I don't know. I'm still like perplexed by this Hounsfield unit because this to me does not look dark like a simple cyst. It looks like a enhancing lesion. So I'm so confused why the HU is 10.
Maybe because clear cell also has a component of fat, so it is just like,
I think it was a cystic RCC that then later developed,
I don't think so.
Oh, you think it was always a solid RCC?
I think maybe they miscalibrated the Hounsfield units that day in the CT scanner.
What are you talking
That
about?
looks like a solid mass, Nelly. Anyway, so wait, if you go back to the MR, we can test out these theories. So Yashant said like maybe because it has microscopic fat, right? So go to the out of phase, see if there's microscopic fat.
Let me pull up
because on coronal CT did look like there was some fatty foci.
I didn't see intralesional fat, but yeah, I don't see any intralesional fat. No.
And then as far as the cystic RCC thing, this thing to me on MRI now looks like a solid mass.
Oh yeah, for sure. But cystic RCC the nodular part can grow, right? And then eventually become a mass, like a solid mass.
It does not usually grow like this. It's usually still a cystic thing with a solid nodule, not
but this
entire thing becomes like a solid mass.
If you wait long enough, maybe it does become a solid mass.
I don't think so. But this is part of actually Yvonne at SAR was presenting PIRADS. Like, remember you're talking about the aggressiveness thing?
Yes.
They said in general, cystic RCCs are much less aggressive, which is
Yes.
why even like Bosniak fours, they're trying to like downplay them as far as like the aggressiveness thing, you know? Just
Yeah.
my theory that like this did not start as a cystic RCC. I think the Hounsfield unit is just like a red herring in this case.
Oh, well, to me, it still looks cystic. And this is 10-year follow-up. And we know like the 5-year survival outcome is like almost 100% in Bosniak force with or without treatment. So this still falls, this 10 years later and the patient's still alive, right? Survival is still 100%. Cancer specific and overall survival.
Yeah. Well, I think to me, the takeaway is like trust your gut. Like that initial one did not look cystic.
Or there's complexity to it. It's not a simple cyst.
Yeah. To me, that could have been a hemorrhagic cyst, but yeah, the MRI would have helped.
Can you show coronal CT one more time, please?
Sure.
Those clefts, they look like fatty foci, or am I just over imagining because it is zoomed?
Fatty foci where? Like here?
Yeah, inside, or is it just super zoomed? That's why it just appears that way.
Oh, I don't see definite fat.
Yeah, I think there's something called pixel mapping where you can like literally go pixel by pixel and see if there's fat in it. That was something that was proposed for like AMLs with tiny amounts of fat, but I think most people don't do it. But I can see what you're saying. There's like a couple of little foci that are more hypodense. But I think overall that thing looks complex. So should get an MRI.
So this case is from Dr. Itani, and she did share it on a social media platform. So this is a youngish male, and there's so much soft tissue thickening of the rectum. There's big lymph nodes in the inguinal area, soft tissue or lymph nodes which have sort of conglomerate in the periportal as well as around the diaphragm and the cervical lymph nodes. And this turned out to be Kaposi.
Okay, sounds good. I'll see what this is up to.
That's about it.
There's already known diagnosis. Oh, actually, it's not your case, so
Yeah.
you don't know.
Yeah. I think they biopsied and then.
No, I'm sorry. I meant, was there a pre-existing diagnosis of AIDS, HIV?
Yes. Yes.
The cases that we saw, I work at Grady. There's a lot of, we have like an entire HIV and AIDS clinic. So we actually see quite a bit of Kaposi's. And we were like searching for Kaposi's cases, and a bunch of them, like, you know, obviously the most obvious is when they have the skin manifestations, but sometimes they don't. And that's what I was saying earlier about the GI tract. Like that was the second most place that they were able to get the diagnosis is GI tract biopsies. But if you start looking through their scans, they have a lot of these findings that you're showing here, like lymph nodes, perivascular soft tissue. I didn't know about I know it can affect the GI tract. I haven't seen like a rectal mass like this, but that's pretty impressive. Thank you for sharing.
Sure.
So this patient came in with a mass, a
Oh my God,
peritoneal
what's going
mass.
on?
And like the team said like they could see a big mass outside the patient. They weren't sure if it was a malignancy. It looked really like erythematous and all the stuff, and they wanted to know if there was a mass. So they did an MRI. It was just a pelvic MRI. We did not do a defecography or like, you know, Valsalva protocol, but you can see that there's just like massive tricompartmental prolapse here. So we have a cystocele. We actually have a Foley catheter in the bladder, but the balloon of this of the Foley catheter is in the prolapse part of the bladder. We have uterine descent and prolapse. And then we didn't really, you know, like we talk about rectoceles and intussusception and stuff, but it basically said that this was like kind of like a little mini intussusception and rectocele. And then as far as the mass that they were seeing on physical exam, it was basically just really edematous perineal soft tissue. Here I'll show you the T2. So you can see it's like pretty bright compared to like all this, other stuff. So it's just like edematous soft tissue. It didn't have evil gray, so it wasn't like an actual mass. Also, because of the cystocele, we had hydroureter that was going into the, descended bladder here. So it was also causing hydronephrosis.
Can you go back to the satchel?
Uh-huh.
What led to the edema? It almost looks like it's strangulated, like it's herniated and then stuck. What like did the patient present that way, or was that after Foley catheter replacement? What was the timing of that?
It was basically, they said there was like a progressively bulging mass over months. So I
Oh,
think
I
it was
see.
all of this just like prolapse, but like you're saying, like I think the soft tissues got really edematous.
Yeah, like it needs to be reduced, like when
Yes. And then we also were like, okay, what caused all of this, right? So the most common causes of pelvic prolapse are multiple pregnancies. But this patient did not have that. So I think they just had really, really weak pelvic
pelvic
floor
floor.
musculature
Yeah.
that was able to
And then you said rectocele. Where's the rectocele?
well, it was more like it wasn't a true like it wasn't like an anterior rectocele or anything like that. It was more like we thought there was like a little mini intussusception here,
Yeah.
but it's more like just like rectal descent.
Yeah, I agree.
Yeah.
And yeah,
And then like complete uterine descent and then
yeah.
the cystocelia.
They could probably like do a sacrocolpexy and just like lift up the uterus, and it'll lift up all the
They would have to do everything though, right? Like they have to do, I think they'd have to reconstruct all of the muscles because everything is just collapsing. Although here, like the levators actually look okay, but somehow they're very lax. So everything was able to descend.
It's like very widened. Yeah.
Yeah.
I don't think they do pelvic floor reconstruction on the stuff. I think they just lift it.
But how would they get the bladder up? They have to lift that up too, right?
Yeah, they can probably suspend that too.
Mm. Go.
So this is an elderly female, and she comes with some GI symptoms, and MR is done. So I want you to focus on the pancreas.
There. Yeah.
Yeah, I see some
Do you have a
like
diffusion?
Yes, I'll show diffusion. So that's T1, and we see
Oh, it's
this
a little bit hypo.
lesion here.
Yeah. Oh yeah, look at that.
And it is showing diffusion restrictions. It's dark.
Oh, there, it's real.
I also have ultrasound for this patient.
Yeah.
wow, it's
And
very
so what was
dramatic on
the
ultrasound.
what was the enhancement pattern?
It is slowly and steadily enhancing, and eventually it enhances fully.
It doesn't
I'm
look like
also
an adeno. It's not
Yeah,
like blocking the duct.
I would check IgG because you can have focal
that's a very good
IgG.
thought. We were thinking in terms of that only.
Mhm.
They biopsied it and it turned out to be eosinophilic pancreatitis that mimics IgG4 closely.
Hmm. Hmm.
Never seen that.
So in
Do you have
fact,
any any teaching points for us, or is it just like extremely rare? Or
extremely rare, yes. In
did
fact,
they have other eosinophilia? Did they have eosinophilic esophagitis?
no other manifestations. And
Oh,
in fact,
wow.
I read this case this morning only, and this was the follow-up. There was a recent paper in Radiographics in 2022 on eosinophilic conditions in the abdomen, including esophagitis, cholangiopathy, liver disease, enteritis, and pancreatitis. I'm just trying to pull that paper. So it shows pretty impressive cases. Again, let me. So they show two cases, one of which has multifocal involvement and the other one has diffuse involvement of the body and tail. And this paper is from
The second
radiograph.
one looks so much like IgG4,
Yes.
like really sausagey and then takes out the, yeah, that one looks.
In fact, IgG4 is one of the differentials for eosinophilic pancreatitis, and they describe focal as well as diffuse patterns. And this is the paper, if readers want to read it. It's from Radiographics, I think 2022.
I don't know, man. This seems so rare that I would just have to like recommend a biopsy,
Yeah, absolutely.
but very cool to know about. Okay, thank you. Bye.
Thank you.